With me here at Shriners Hospital in St. Louis is Professor Stephen Mumm, who for 25 years has worked to do the genetic characterization of hypophosphatasia. Nurse Karen Mack, who in 1983 joined our research center and has, I confidently say, taken care of more pediatric patients with hypophosphatasia than anybody in the world, numbering now about 250. Gary Gottesman, who's a medical geneticist, will be here in a few minutes. And Mr. Vinny Bajanki has been responsible for illustrating in many aspects of what we publish from this research center. So with that in mind, I'll start with this lecture. Disclosures, I would say none now. I used to have them from Anobia Pharma in Montreal, Canada, and then from Alexion Pharmaceuticals now in Boston. That was consulting fees and travel and grant support, but it's been a number of years now so that I could say no longer disclosures relevant to this talk. By way of background, I tell you that in human beings, there are 4 genes that encode alkaline phosphatases. 3 are found in specific tissues, placenta, intestine, germ cells, and therefore called tissue-specific alkaline phosphatases. But the subject for this afternoon is ubiquitous. It's the alkaline phosphatase in bone and liver, and it's therefore called tissue non-specific alkaline phosphatase, hereafter TNS-ALP. The clinicians know that you could distinguish bone from liver alkaline phosphatase, but that's by post-translational modifications. The peptide sequence is the product of the same ALPL gene. So hypophosphatasia, it is a heritable metabolic bone disease, and its key characteristic is defective skeletal mineralization, so that in infants and children, this would result in rickets, and in adults, it would result in osteomalacia. Its biochemical hallmark is low serum alkaline phosphatase activity, hypophosphatasemia, a word that's been in the medical dictionaries for decades now. And it's an inborn error of metabolism, and we actually knew this in the pre-DNA era where autopsy studies of the severe forms showed a global deficiency of tissue non-specific alkaline phosphatase, whereas in the intestine and placenta being from a separate gene, the levels there of alkaline phosphatase are normal. And I would say that loss of function mutations in the gene ALPL encoding tissue non-specific alkaline phosphatase is the etiology for hypophosphatasia. You can usually, with conventional methodology, identify 1 or 2 defective alleles in ALPL. Only sometimes it's more difficult to get to what is the genetic basis for hypophosphatasia, and that is loss of function mutations in the ALPL gene. And we now are approaching 400 different defects worldwide. Interestingly, with 80% approximately being missense mutations, so for a homodimer with mutations scattered throughout the gene, you can imagine how different degrees of severity and dysfunction of tissue non-specific alkaline phosphatase activity might be the result. I would also mention that new mutations are actually quite rare in hypophosphatasia, and this has importance. Hypophosphatasia, about 800 literature cases. I think we really do know the clinical presentation, the radiographic features, biochemical features, the bone biopsy features, even the etiology quite well. So a single case report needs to have more to it, I think, to really be adding on to what we already know about the disease, thanks to all of these reports. It affects all races, ethnicities. For some reason in the United States, we find it's rare in folks of Black background. We don't have an explanation. Its incidence, though, for the severe forms that I'll show you is about 1 per 100,000. For the more mild forms, the incidence isn't all that clear, but it's speculated about in various publications. It's a fascinating form of rickets or osteomalacia because circulating calcium, phosphate, and vitamin D levels, 25-hydroxy-D, 125, are not low. And indeed, in the severe cases, you can have rickets, yet there's hypercalcemia, and there's actually hyperphosphatemia as well. So it becomes apparent that something is blocking mineral from going into the skeleton. We're very interested in the hyperphosphatemia, and now EPUB in bone, you'll probably see it in about a month, is our pursuit of the pathogenesis of the hyperphosphatemia, present in 93% approximately of non-life-threatening pediatric forms of hypophosphatasia. And here, in this study, we found low circulating FGF levels and normal FGF23 and secreted FRP4 levels in pursuit of trying to explain what could be a rather complex but fascinating physiology leading to high blood phosphate levels as well. Its inheritance for the severe forms, perinatal and infantile, is autosomal recessive, but once you get out into the childhood forms and adult forms, they can be either autosomal recessive, two mild defects combined, or autosomal dominant. We'll talk more about that. I see it as the bone disease with the greatest range of severity of all skeletal disorders. We know about the severity of OI, but as I'll show you, I think hypophosphatasia is even a broader severity range. And I think it's also okay to say that it's the last rickets or osteomalacia to have a medical treatment. Not all are treated perfectly, but knowing the pathogenesis, most rickets or osteomalacas have had some good or very good treatments over the years, but hypophosphatasia was the orphan until recently. The nosology is important. It's clinically based and by inheritance pattern. This is something that began in the 1950s. A nosology, a clinical classification according to age at presentation, with the earlier onset being generally more severe. And here's the general nosology with most mild at the bottom, odontohypophosphatasia. I'll show you this. And at the top, the most wicked, perinatal hypophosphatasia. Perinatal looks like this. There's almost a completely unmineralized skeleton in the stillborn. Accordion-like folds in the forearm skin. There's no bone there to stretch out the skin. And of course, the skeletal disease is obvious at birth, stillbirth, deformed limbs, respiratory compromise, apnea, bradycardia, all obvious at birth and almost invariably lethal within a few days or weeks of life. Survivors are very rare for perinatal hypophosphatasia. Then we have the infantile form. Little one looks okay at 1 month of age, but then by 5 months of age has proptosis, a bulging anterior fontanelle, rachitic changes in the rib cage. So this is a form where the patient survives long enough to manifest hypercalcemia, often hypotonia, perhaps related, nephrocalcinosis because they're hypercalciuric. The skull doesn't grow, so there's a functional craniosynostosis and failure to thrive, chest deformity, often leading to pneumonia. And interestingly, seizures, vitamin B6 dependent seizures are characteristic. all beginning before 6 months of age, but not seen at birth. Here's the functional synostosis, if you will. You think you have widely separated sutures, but that's really hypomineralization of those bones that's giving you that as, in a sense, a illusion. Infantile hypophosphatasia, about 50% are described as succumbing within the first year or so of life. We have more precise figures now. Some would improve spontaneously, and others would persist with sequelae of rickets. And this has been looked at much more carefully. I show you these title slides to tell you that the natural history of perinatal and infantile hypophosphatasia has been looked at in a retrospective study designed especially to match what would be the clinical trials of aspartate alpha for these most severe forms of hypophosphatasia. So look there for details. And then I will come to treatment, but there in JC-E&M back in 2016 is how aspartate alpha treatment has improved the survival of perinatal and infantile hypophosphatasia, again with details there about the respiratory insufficiency, et cetera, that's part of the clinical complications of the most severe hypophosphatasias. Here's what infantile survivor looks like. Thin maybe because to burn up energy to walk, but this is a debilitating form of hypophosphatasia. This is a survivor of infantile. More mild is childhood. These two brothers have lost deciduous teeth with their root intact. This can occur bloodlessly, painlessly, scare parents. You pull out a tooth, they do, the children, with root intact, often the lower incisors, the upper incisors then, and then sort of going posteriorly with increasing severity of the childhood form. So there can be, characteristically, premature loss of deciduous teeth. That's before the 5th birthday. Only sometimes is there short stature. There can be delayed walking, rachitic deformity, bony craniosynostosis, muscle weakness, and with that, a waddling gait. But this you diagnose after 6 months of age. That's when it presents. We're interested in the nosology here, and back in 2015, looked at the nosology and actually expanded it out somewhat, having experience then with 173 patients over 25 years. Severe childhood looks like this. You would see bony changes obvious on X-ray, debilitating in this sense. And then you have a mild childhood form. There'd be some bony changes, but the little child can run and jump and not really debilitated at all. More mild than that is adult hypophosphatasia, typically presents during middle age, premature loss of adult teeth. Actually, not, you wouldn't say premature after all. When do you lose your adult teeth? Loss of adult teeth is probably the right way to describe it. And then recurrent metatarsal stress fractures that heal at first, then slowly, then not at all. Development of femoral pseudofractures, and then interestingly, pseudogout chondrocalcinosis and deposition of hydroxyapatite peripherally, typically during middle age. Here's an example, 3 ladies from Oklahoma, no bowing of their legs. They started having these fractures in their feet, middle age. They had pseudofractures. These are not acute fractures. They persist for a decade, and if you do a bone biopsy, you'll see osteomalacia. Most mild is odontohypophosphatasia. This can apply to children or adults where there's no radiologic or even bone biopsy evidence of skeletal disease, yet loss of teeth. This little guy has odontohypophosphatasia. He's lost his incisors, but he can run, and if you ask him to hop like a frog, he could do that. This is a very functional kid with no X-ray changes to suggest bone disease. And here's how mild hypophosphatasia can be. This little girl lost 1 incisor, root intact, before her 5th birthday, and then osteoclast chewed away the tooth roots, and she properly exfoliated the remainder of her teeth. No radiographic changes, very healthy little girl. We call it one-tooth odonto. So what's the pathogenesis? Tissue nonspecific alk phos is a cell surface phosphomonoester phosphohydrolase. What would it cleave? It cleaves these phosphate esters, phosphoethanolamine, pyridoxal phosphate, the most abundant form of circulating vitamin B6, and also inorganic pyrophosphate. When we discovered the elevation in pyridoxal phosphate, we knew all foods contained vitamin B6. This is work with Stephen Coburn in Fort Wayne, Indiana, and saw that there was a tremendous elevation in circulating pyridoxal phosphate, yet its hydrolysis product, pyridoxal, would be low only in very severe hypophosphatasia. The tissues were happy, the 4-PA degradation product was in normal levels, so we reckoned correctly that TNS-ALP was regulating the extracellular space on cell surfaces. In general, but very much general, there's a correlation between the circulating alkaline phosphatase activity and the severity of hypophosphatasia. You see it here. Odonto is not quite in the normal range. All hypophosphatasias here in our research center have low levels, but there's overlap between and among the various groups. So one alkaline phosphatase will not have important prognostic implication. The plasma PLP level is similar. Odonto is just a little bit elevated on the left in green, and infantile more substantially elevated, but look at the overlap. So measuring PLP also doesn't have perfect prognostication information. Where's the phosphoethanolamine coming from? It's part of the phosphatidylinositol glycan linkage apparatus for the protein TNS-ALP. That's where it's coming from in the extracellular space, and this is the linkage apparatus for ALK phos. The pyrophosphate, you see this in adults, calcium pyrophosphate dihydrate, chondrocalcinosis develops, and these adults can develop holes in their hand bones, characteristic of pyrophosphate arthropathy. So here's the major culprit in hypophosphatasia. It's the extracellular accumulation of pyrophosphate. You know that in bone formation, you have resting chondrocytes. They proliferate, they hypertrophy, and then there should be mineralization of the cartilage. Well, there's pyrophosphate lurking in excessive amounts when the hydroxyapatite crystal comes out of the matrix vesicle. So you form crystals, and we know this from work with H. Clark Anderson, in matrix vesicles, but then they don't grow, and this is why you don't mineralize your skeleton. Jose Luis Mian lent me this nice cartoon. Where's the pyrophosphate coming from? ATP gets out into the extracellular space, hydrolyzed to form pyro. There's an ANK channel that allows pyrophosphate to come out, and then it's the job of TNS-ALP or TNAP to hydrolyze and release phosphate to allow mineralization to occur. So diagnosing hypophosphatasia, a little tricky in that, keep in mind, adults have lower levels than the pediatric folks normally. And if you don't pay attention to the age-appropriate ALK phos levels, you can be misled, miss a diagnosis, or make it incorrectly. We like the Mayo Clinic's normal ranges for alkaline phosphatase. But importantly, not everything that causes low ALK phos is hypophosphatasia. Here's a differential diagnosis that includes such things as vitamin D intoxication, hypoparathyroidism, other bone diseases, Cushing's disease, milk alkali syndrome, and improperly collected blood tubes. So there's an extensive differential for hypophosphatasemia. Yes, the greatest range of severity of all skeletal diseases, the last rickets to have a medical treatment. Infantile hypophosphatasia, we tried years ago to treat it by enzyme replacement in the form of giving Paget plasma, get the alk phos up. It really didn't work. 4 patients that we treated by giving this, getting their alkaline phosphatase transiently into the normal range, kept there for a length of time, did not rescue these babies. We purified placental alkaline phosphatase, gave it knowing that it had the same catalytic activity to this little boy. Corrected his circulating alk phos. He still went on to succumb to the hypophosphatasia. So we were treating the circulating level but not getting anywhere clinically. And then it became, can we increase alk phos in bone itself? We tried marrow transplantation with some success. Engraftment, maybe a few osteoblasts, helped the rickets. Adult hypophosphatasia could be approached with off-label use of teriparatide to drive osteoblasts to make more alkaline phosphatase. There's been about 50% success using this approach for the adult form of the disease. Our patient healed this stress fracture or pseudo fracture over this course of time. Then several groups, especially Jose Luis Millan, developed mice lacking tissue nonspecific alkaline phosphatase. We studied them and they beautifully mimicked the infantile form, including having vitamin B6 dependent seizures. So that we were very happy to hear from Inobia Pharma back in about 2005 that they could target alkaline phosphatase in bone to bone. The homodimeric catalytic forms were present, hooked to an IgG1 Fc fragment for purification, prolong the circulating half-life. But then a decaaspartate motif was put in to target the bone, and their studies here in a rat showed that, oh, actually, these are the mice. Here, the mice dying if they weren't treated, but here are the controls, and those who got this preparation of targeted alkaline phosphatase survived. In fact, having this decaaspartate motif binds the hydroxyapatite crystals about 32 times more avidly than if you don't have it present. So then studies began with enzyme replacement therapy, first, of course, to the mouse model. The mice, as I showed you, did very well. And then you turn to clinical trials, knowing that this needed medical treatment. As I'll show you in 2015, aspartase alpha Strensiq became approved as a enzyme replacement therapy for hypophosphatasia. The success with 11 patients with either the perinatal or infantile form, we published back in 2012 after 1 year of experience using this in the New England Journal of Medicine. Maybe some of you saw the first patient on the verge of requiring intubation, but in these patients showing radiographic improvement as early as week 6. The first patient, look at the terrible rickets at baseline, but how much better at month 21. And the clinical improvement that came along with the radiographic change, sometimes a biochemical improvement, resolution of hypercalcemia, was 1 year of treatment with her at 2 years of treatment at age 3, and 7 years of treatment riding a bicycle, requiring along the way craniotomy for craniosynostosis and scoliosis surgery. The adverse events are reported in detail in these publications. Please look there if you're interested in the particulars. But most of the complications or the adverse events were related to childhood or mild or moderate and adjudicated to be unrelated to the studied drug. Some of the more serious ones were craniosynostosis. The treatment doesn't seem to prevent that in these infants. One patient developed deafness, maybe unrelated. There was one episode of chronic hepatitis reported as the more serious adverse events. One little one before the skeleton healed substantially died of septic shock, thought to be unrelated to the study drug. So go there for those details. There's a supplementary appendix with that paper that tells case by case what the presentations look like and what the responses were. And last year in Lancet Diabetes and Endocrinology, the 9 patients who went into the extension study are reported out for their 7-year outcomes. And you could read about how well they did in that publication. Basically, the treatment was well tolerated. These infants and children with life-threatening disease showed a significant skeletal mineralization as early as at 3 months, and then it was sustained radiographically over the years. A number of them required ventilation and no longer. The last one came off a vent after 4 years. And the survival was 90%, and this is different from the natural history. We turned to children. We enjoyed doing this study here, where you could then test their physical abilities, and that showed improvement in not only radiographic skeletal disease, but also physical performance, iliac crest bone biopsies, biochemical alterations, and growth. You could do these kind of functional tests in children. You could show that the radiographs improve. Here's just 6 months of therapy. The metaphyseal widening would go away. Their height Z-scores for the children would get better over a length of time. And they reported increased strength, endurance, mobility, sometimes after several weeks. A little wobbly at baseline, but then after 24 weeks of enzyme replacement, natural gait. And you can see the shaded area is the normal range for a 6-minute walk test. These kids entered the normal range, and it was sustained for 5 years and 7 years on aspartate alpha therapy. Baseline for this girl, she could barely hop, but she's able to do this after 6 months of treatment. And strength, agility, and composite standard scores go into the normal range for the children with what we would say had the severe childhood form of hypophosphatasia. Pain resolves, disability resolves in children, and the safety is detailed in the publications. There are nuisances of red spots in the first month of treatment. They tend to go away, but then you can have fatty blobs, hypertrophy of what otherwise looks like normal subcutaneous fat. But we found that similarly, mild to moderate injection site reactions were the most common adverse event. And these sort of things got clearly better. And the improvements were sustained through 5 years of treatment. This is one of our patients who first walks at 3 years of age. After 1.5 years of treatment at age 4.5, before treatment, I should say, still has a wobbly walk, but many of you have seen this picture. So tries to capture how much better they got, but the details, again, are published in 2016 in JCI Insight. This is the 5-year experience with the children. And then there's published Priya Krishnani at Duke, 5-year efficacy and safety of aspartate alpha for adults and adolescents with hypophosphatasia, where you'll see that they walk better, that their bone biopsies show some improvement in their osteomalacia. The details are there. So that in 2015, the last rickets or osteomalacia awaiting a medical treatment had the approval of aspartate alpha, first in Japan for all ages of hypophosphatasia patients, but then in Canada and Europe for pediatric onset, and similarly in the United States for pediatric onset hypophosphatasia. Even if you're an adult in the United States, it was approved. On commercial product, this little one with this severe childhood hypophosphatasia, does better at 3 months. We enjoyed seeing this at, what, month 9 of therapy? And that's 1 year. So laboratory diagnosis, these are important points. They're sort of maybe almost caveats, but I've tried to capture it in a perspective of where we are now with a treatment for hypophosphatasia. Last few slides, Laura. Yes, laboratory diagnosis, you expect low alkaline phosphatase, elevated B6, and you expect to find an ALPL mutation, but that does not diagnose hypophosphatasia. You could see this in carriers. So the doctor with the patient needs to diagnose the disease itself. You don't do it by biochemistries and by mutation analysis. You need to recognize the consequences of the disease to achieve a diagnosis. This is expected up there, but not sufficient for diagnosis. Keep in mind, osteoporosis is seemingly far more prevalent than hypophosphatasia. We've come across some concerns where atypical femoral fractures emerge during bisphosphonate. Remember, bisphosphonate has as its parent molecule PLP, inorganic pyrophosphate, where the oxygen is changed to a carbon to keep alkaline phosphatase from degrading it. So there's some worry based on what happened with this woman who was a carrier or developing early adult hypophosphatasia for being put on a bisphosphonate. There are diseases where you go in the opposite direction, ectopic calcification when the pyrophosphate levels are low. This is generalized arterial calcification of infancy, pseudoxanthoma elasticum. These heritable disorders are telling you that if you drive pyro too low, there is these diseases where vascular calcification is a complication. So you want to get the dosing right and get the substrate levels, you would hope pyrophosphate lowered and perhaps maybe just above or in the top of the normal range. Unfortunately, pyrophosphate assays are not available commercially. I was heartened to do cardiac CT for calcification in a 68-year-old woman who, interestingly, had no vascular calcification at baseline. So was pyrophosphate accumulation actually protecting her? She was treated quite successfully with aspartase alpha, and 8 months later hadn't developed any vascular calcification. So we want to keep this in mind in getting the dose right and following these patients. It's interesting for the rheumatologist, maybe it's not all bone, but calcific periarthritis, a paradox of hydroxyapatite around joints, is a paradox that you're putting mineral down around your joints and not into your bones. This can be one of the manifestations of hypophosphatasia. And with those caveats that I think need attention going forward, I'll stop here and approximately on time for this talk.